All right. Well, let's get started. Welcome to our meetup, everybody. Our plan for today is to learn a bit from Lisa Besler about her role as the clinical director of the practice where she's at. So I'll introduce her in a second. But she's going to share with us some of the challenges that she had prior to implementing Practice Vital, ways that she uses it in her practice, and then we're going to open it up to your questions for her specifically. So we won't put her too much in the hot seat. We'll make sure that the questions are relevant to her role or to the role of a clinical director. And then we'll allow there to be time for just open Q&A about Practice Vital in general, kind of after we take her off of the spotlight. And we're trying this out. We've done it a little bit. We did it, some of you might remember, with Whitney Owen's practice, and people loved learning from their clinical director. So I think it's just a great way to learn from each other. That's really the goal of these meetups, is not a specific training from our team, but to feel like you can ask questions of each other and just learn best practices, workflows, what works, maybe ways that you hadn't even thought about using Practice Vital. I learn the most from all of you when I'm doing trainings. I often find, oh, wow, yeah, I never thought to look for an answer to that question, but it's there. So share your knowledge with each other. And that's really the goal of our meetups. So we're here every month. Sign up each time to join us. We'll have a different focus each time. And so without much more, I will introduce Lisa. So Lisa Besler, am I saying your last name correctly?
You are, yeah, you've got it.
Awesome. She is the clinical director of DBT of South Jersey, a licensed professional counselor, a Linehan board certified DBT therapist, awesome, and a leadership coach. She works with clinical and administrative leaders to build clarity, strengthen decision making, and build systems that create lasting impact for teams and organizations. She also leads a monthly leadership coaching program called Elevate Your Leadership and shares her work on Instagram and other platforms. So do follow her if you want to learn more through Lisa Builds Leaders. So this is really great. And of course, she is a Practice Vital customer and has been using it for over a year,
hmm
maybe longer. And so she's here today to help all of us. So Lisa, why don't you start by just sharing a little bit about the background, your role, a bit more about who you oversee, and kind of how comfortable your team is or was even before using Practice Vital with data.
Yeah, thanks so much for the introduction. So, as you said, I'm the clinical director at DBT of South Jersey. I primarily oversee our clinical team, but I really work with our administrative team as well during our weekly leadership meetings and things like that to have good flow across the organization. So we have two locations. We have a location in Voorhees and a location in Morristown. So our team is kind of in two places in South Jersey. And when I think back to before we were utilizing Practice Vital, one of the things I can say is that information for one was a bit disjointed. We had to kind of pull information from different places. So we had tables that we would try to use to show clinicians their numbers. These were all inputted manually. We were taking the information manually from our EHR and trying to put the numbers in so that staff could see how they were performing week to week. I think one of the things with that was there was a bit of a lag in that information. And then, of course, human error, checking for accuracy, and things like that. The other thing was we didn't have one central place to kind of track both all the things, session counts and targets and revenue and retention rates and cancellation rates and even documentation. Everything kind of lived in a different space. And I think we were getting by, but one of the things that I really saw and the thing that I think has been helpful in using Practice Vital now is that we were kind of always a little bit behind. So we were looking at information, even when we were trying to be as quick as we could, there was a bit of a lag. So we were looking at, 2 weeks prior. I mean, there was a time when we were like way back when we were running data monthly. So we were looking at last month, but then we didn't have this month. And so I think having the real-time updates, at least for me and guiding the team, has been one of the things that's been really helpful.
I love that. Yeah. And I think I hear that a lot in terms of especially one cohesive place. I
Yes.
always say the data tells a story. And so if it's all in one place versus like, here are the session counts, here are the note counts, here's the retention, all in different spreadsheets, we can't really tell a story of what the data is trying to tell us. And if we can see it all together, we can paint a picture of, oh, this is an issue of client engagement. There's a lot of cancellations and then retention is dropping. Those two things go together. So thank
Yeah.
you for sharing that.
Absolutely. I think too there were a lot of things that we kind of like hypothesized about.
Mm,
Like I can think about things like caseload. We would say like, well, what's the right number of clients that the average clinician at DBT of South Jersey is going to need to have on their caseload in order to be successful in meeting their metrics. For us, our metrics for productivity are 23 session counts a week is what we want to see. And, we didn't really know. And now I can look and I can see, our clinicians who consistently meet their, utilization and they're always on track versus clinicians who may struggle. Well, what's the difference in overall caseload size, too, right? And drilling into some of those things. It's also been helpful, I think. And this is another thing that we kind of like hypothesized about, but tracking the actual revenue that we get per session per clinician has been really helpful. So, what we had found is that our clinicians who we've been in practice about 7.5 years. And so, our clinicians who started with us at the very, very beginning, when maybe 7.5 years ago, our rates were a little bit lower, we were noticing that newer clinicians coming in were actually sometimes having higher, revenue per session than our clinicians who had been here forever. Well, it makes sense when you think you have clients who come in 2018 and the rate is one thing, and if we're not catching and tracking and, increasing rates appropriately and things like that, that all becomes an organizational bleed.
mm.
And really, things were kind of misaligned with that. So that was another way that we were able to drill into some of the data. I'm just trying to think of some of the big picture things that we've used it for.
Yeah, yeah, that's really helpful. Um, yeah, is there anything you feel like you are regularly or a challenge that you face in your practice um, that shows up around team alignment or follow through, decision making, that you can speak to in terms of how you address that now with Practice Vital?
Yeah, I think one of the biggest things, at least working in a clinical practice, a lot of the clinicians on our team are not necessarily, data people, and numbers
Hmm.
feel really scary. And I think one of the challenges that we had was introducing the idea of numbers. And this is independent of Practice Vital, even when we were using our, our dashboards and putting everything in manually, was helping people to see, this information is really here to help you and to support you and to project you, help to project so that you can be more successful within our organization and helping to, I don't know, just like bust the myth that numbers are scary or there's something that's like bad that's going to come from them. And we really believe in a lot of transparency. I think we've always been that way. And I like to know that clinicians are looking at the same thing I'm looking at. And I think that's one of the things that's been very helpful is like, I don't have, secret metrics that you don't have. We're looking at the same metrics, we're seeing the same things. And I think when I think about an overall organization, you always have your top performers, maybe like your mid performers or people who maybe struggle to perform. And the conversations can be different, of course, based on how someone is doing, but using a tool where they can see their data and I can see their data, the conversation is very transparent. We both know what we're walking into, we both know what we're looking at. And so I do think that that's helped to guide discussions and help to decrease some of the anxiety that people maybe initially had around their numbers. And for some clinicians, it's been really great. Like they have a lot of accountability and sense of mastery, even over projecting their own schedules or looking at their own trends and seeing, well, what got in the way this quarter from, I wanted to meet this number, but I met this number instead. And, we can look at information week by week, or we can look at retention, like you said, and cancellations and see, okay, well, all right, you've got 38 clients, you only need to see 23, and that isn't happening. So what's the piece that we're missing? Like it must be something else then. It's not your caseload size, it's something else that's happening. Where is it coming from?
Mhm. Yeah, I love that. Would you be willing to speak to how often you meet with clinicians and kind of what that looks like?
Yeah, so we meet pretty frequently. Our leadership team meets once a week as a leadership team, and there's 6 of us that come together. So in that meeting, it's our supervisors who are directly supervising staff. We have our admin team there, our office manager, and we start out that meeting by looking at our Practice Vital information. And basically, what we do is anybody who's off track or off target, or if we're seeing certain trends, we kind of drop down that individual or those numbers to drill into them further and kind of look and see what's contributing to that or telling the story. We then take that information, and individual supervisors would use that for our introductory clinicians or anybody who's a new hire on our team. They're going to be meeting with their supervisor or someone from the leadership team at least on a weekly basis. Sometimes it can be more than that because if it's a new hire, because what we'll do is we'll give both some clinical support and then I may come in and do some additional administrative support and teaching. So that way the person is learning things like how to understand their numbers. Numbers aren't scary, the transparency around that. And then for my clinicians on the team who are independently licensed, they're my high performers, they're self-sustaining, they really get it and they know what to do and how to run with things. For those team members, I'm really only checking in once a month and kind of saying to them, what are you noticing? What are you seeing? We pull up their Practice Vital report during those meetings to have insight into trends. But for those individuals, we can meet a little bit less frequently.
Awesome. I think that's super helpful to think about the leadership meeting as a touch point of let's use the data to inform what we're actually discussing today and our action steps. So it sounds
Right.
like it's kind of directing then what you do in the following week or month, both on a practice-wide scale, but also with each individual clinician.
Absolutely. And I think it helps to coordinate the overall team because if we see someone who is starting to trend down, for example, that allows me to look at that and say, okay, well, this person may need some more intakes. They may need some more clients coming in. It also puts it on, our intake office manager's radar of, okay, when you're scheduling, you want to be looking at this clinician because this clinician is experiencing, a dip in their productivity and their utilization. And so let's make sure everything's coordinated in order to, help them be successful and get them to where they need to be. It also is really helpful in looking at cancellations.
Mhm.
So, and one of the things that we found that can be a bit of a sticking point. So, for our organization, if you cancel within 24 hours, it's the full session fee. Although we've been able to see that there's some variability in, how clinicians implement that. There are some clinicians who, maybe struggle or feel bad if clients need to reschedule or they're canceling. So that also helps us to look at limits. And I think from even like an employee health standpoint, outside of just numbers, if I'm constantly stretching my limits and rescheduling and things like that, I'm going to have a staff member who might burn out a lot faster than somebody who's really like sticking to the policy and seeing clients in like their designated window. So it has it starts as a maybe like a numbers review and we're looking at the overall utilization, but it has a broader impact in just the overall health of the organization, but also the health of our team and our employees. Like we can catch trends that might be impacting them from, more of a work-life balance perspective.
I love that. And you're really emphasizing how data is so supportive and can be such a benefit to the clinician. I think it's really a misunderstanding when people come in and think like this is going to seem icky to a therapist. I think it's all about how we're both presenting it, but also how we are using it. And you're explaining all these ways that are, I want to make sure I give them more support. I want to make sure I have the right caseload for them. I want to make sure I'm preventing burnout. I want to make sure I help them set limits. And the data is helping you to do that. So I think that comes through really well.
Yeah, absolutely. I think that's such an important part of it. And that goes into the idea that the numbers aren't scary. They don't have to be scary. They can just be information. And that's usually how we'll talk about it. When I meet with a team member, I'll say, okay, like this is just information for us. Let's get really curious about it and take a look and see, what do you think this is showing here? What do you think the story is? Or if somebody's, retention rate is down, again, just getting really curious about that because sometimes it has nothing to do maybe with their actual retention. We have a client who came in November and then they decided to go on vacation for the whole month of December, right? But they're coming back in January. That's going to look like a client who hasn't been retained, but the retention time is just going to take a little bit longer. And so again, I think approaching it from that spot of curiosity helps to keep the defenses down. There's always going to be, people or team members who are maybe more nervous or have more anxiety about it. But we do our best to just drill in the idea that we're just trying to be curious. It's just information. Let's take a look at it together.
Yeah. Yeah, so I think you've spoken a lot to the impact that it's had in terms of transparency, promoting greater accountability, more support. Anything else that you haven't mentioned yet that you would share just about kind of the impact that it's had on your team as a whole, or meaningful outcomes as a result of it?
I mean, I think it's had a lot of meaningful outcomes. I think the biggest thing is it helps us to intervene in a more proactive way instead of a reactive way. That's one of the things that's been really helpful. I do think that if I look back to the very start of our organization when we were manually pulling data and there was delays in that, you know, I would be sitting in leadership meetings or sitting with team members and I'm saying, oh, yeah, what's going on here? Because maybe the person's you've only been averaging 18 and our goal is 23 and what happened? But we're looking at last month's data and, you know, it can feel, misaligned or reactive, or maybe that's not the story right now. And so I think for us to be able to see not only what's happened, but also trends that are coming up, like how someone is scheduled out and how they're trending over time, I think we're allowed to be a lot more proactive and it feels better from the employee standpoint, where before I felt like I was kind of maybe putting out fires or catching things just a little bit too late. And then it felt like more of a sense of urgency. Like as a clinical director, or as a manager, I felt a sense of urgency, like, oh my gosh, wait a minute, I've got to get in here and do something right now because this is not going the way I want it to go. Whereas now I have an idea of how it's going to be going. And so it's easier to intervene sooner or say, okay, well, what we need to do is this person needs to really focus on just retention, building rapport, getting really aligned with their clients. Because if they stop churning through clients, they're going to feel a lot better. They're going to be right where they need to be. They've got plenty of intakes. Clients are coming in. We've got to focus on this other piece. So definitely a better ability to be proactive than reactive. I also think it's helped us. Listen, I would love to be able to say everybody at the organization is like 100% productive all of the time, but that's not real life. Nobody's 100% productive all of the time. But it has helped us to manage, and I think it's decrease the spread where we might have had like our really high performers and then you're like really low underperformers. I think the spread's gotten smaller. And from a revenue standpoint, we had our most successful year that we've had since we opened, which was a really big goal of ours and we were really excited about. And so just by shrinking that spread and the disparity between the two, I think that that's really helped. Yeah, it was exciting to see that.
Yeah. Yeah. Yeah, I love what you said about urgency. It's not just your urgency, but imagine how that feels to a clinician to say, you've had 40 new intakes and now you're at seven. And, 8 months or 9 months has gone by and there's sort of this like, oh no, we want to do baby steps along the way. Imagine if that person had started in a weekend, you caught that two people aren't rebooked. Well, let's talk about those two people and let's work on this specific effort around rebooking, which is manageable and it's manageable for the supervisor, but it's way too much and this is kind of my thought coming off of a training just now where somebody looked at their clinician data and it was like, oh my gosh, but how do I even intervene at this point? And that doesn't feel good to anyone. So I think staying on top of it, small actions along the way are going to lead to big changes.
Yeah, absolutely. And I do think it's more empowering for the team members too. They're
Yeah,
seeing exactly what I'm seeing. When they're able to understand and interpret their own trends, that's helpful. And they feel like they can better project. It's funny, I'll have clinicians that I'll meet with and they'll say to me, "Oh, I'm really worried about my numbers." And I'm like, "Well, what do you mean? Like your productivity is great. Like you've been doing really well. Tell me more about that." And they'll tell me about their upcoming trends. They'll say, "Well, it's been going really well, but this person is discharging and it just hasn't hit the numbers yet, and this is going to happen." And so I already know. Like they start to be able to read their own information, their own trends to be able to identify what's going to help them to be successful. And ultimately, that's the goal. Like I say to my team, if you're using these tools and you can use them yourself, like we're probably going to spend very little time actually in the numbers. If somebody has the knowledge and they're self-managing and they know how to interpret it, then they're adjusting and they feel a sense of accountability around that and a sense of empowerment versus me having to interpret things for them.
perfect. I love it. I want to give everyone a chance. I'm sure some people are just chomping at the bit with questions for Lisa. So let's open it up. Ask her anything that relates to her workflow or her role, how she uses Practice Vital. Again, we'll get to some of the more general Practice Vital questions in a little bit. Um, Maybe raise a virtual hand if you want to speak, just so we can get a sense. You can also put a question in the chat. This is such a good opportunity to learn from someone else who might be in your role. She did such a good job. Maybe she covered everything that you wanted to know. Anyone have questions for Lisa?
Yeah, I see a hand raised. Go ahead.
Hi, how are you?
Good.
I have a question on how you, and this might be just an overall general Practice Vital question, but we are new to Practice Vital. We just started using it this year in January. So we are new. We're just diving into it and getting to navigate the system. But I'm wondering, how do you handle regular cancellations within your software and how they show up? Do you have your staff delete the appointments? Like if let's just say they're out sick or something, maybe, rather than that showing up as canceled appointments that would go against their utilization or any trend or anything like that.
We personally will just have clients cancel them. So they stay, like technically they stay on the report. So if somebody's out sick one day, we're going to just cancel those. If the appointments are being rescheduled, our EHR allows us to indicate that it's a reschedule. So it kind of moves the appointment versus looking like if somebody was going to be out for 2 weeks or something. Obviously, we're not going to put all of those in as cancellations. They would just become rescheduled appointments. But we do, when clients cancel, if a clinician has to cancel, we label them in that way. I don't know what other team members, other people do, but.
Okay.
And then
Okay.
I think
And
we would look at that. Sorry, one more thought on it. I think we
and
would
that's
look at that
okay.
more in like a bigger trend. So if somebody has to be out, let's say we had somebody who had like an emergency that came up, right? And so then their
Mhm.
entire week is going to get canceled out. We're going to look at that more so in the overall trend for that individual and saying like, okay, well, we don't expect them to be trending like on track or be meeting their utilization goals that week because they had a family emergency or they were sick. We kind of look at that as a blip and we try to look at numbers based on like quarters and then the overall yearly picture. For us, our session count targets, our metrics, we drop out, so to speak, about 4 weeks out of the year. So we expect people to see 23 clients a
Okay.
week, but overall, we're saying that they're going to do 1,100 sessions a year. So automatically, we have some built-in room that we're expecting, like
Mhm.
you're not going to work all 52 weeks of the year. So in theory, if somebody has like an off week or a sick day or something like that,
Sure.
that is going to already be taken into account. The one thing I will say that's been really helpful this year, because this is the first time we're going into like a full second year with Practice Vital, I've taken a look at employee trends. Like I have some people who like to vacation a lot, right? So we're saying 4 weeks, but I have some people who are vacationing for 8 weeks. And so for those individuals, they're never going to meet their utilization and their metrics because they're always going to be 4 weeks worth of session count targets behind. So for them, I'm able to say, okay, like our number's 23, but you like to go on vacation 8 weeks out of the year. Your number's 25 if you want to hit 1100. So it's also
Okay.
been very helpful for us to tailor to individuals.
That yeah, that is very helpful. I like that. Um, my other question was, do you have specific reports that you like to run on a daily, weekly, monthly basis that you are wanting to share?
Yeah, so we will run, we recently transitioned to being an in-network provider. So I will run a note report every day to see that notes are being submitted and signed in a timely manner. So every day I send out the note audit and anybody, so we have like a 24-hour timeline. And so anybody who's not within those 24 hours, they're going to get their audit that they have notes in the queue that need to be completed. Those are
Okay.
I feel like that's the only one that I'm really sending to the team. Besides that, I am going in each week in our leadership meeting and I'm looking at like our overall utilization. And then we're
Okay.
drilling down into individual clinicians if somebody is, trending off track. So I love the like green, yellow that come up on the screen because it's really easy to see. So we use that, and I'm not sending that out because our clinicians can see that. But
Right.
I will use that in our meetings to kind of guide our discussion.
Okay. Thank you.
It looks like there might be some more questions in the chat. Let's see here. Oh, okay. Somebody said our practice uses a clinician canceled option as well as cancellation. So we can see the difference with cancellations. That makes sense.
Oh, yeah.
Whole group practice.
Can you do the okay up there? Click on the okay. No, so we can see. I unmuted you, so be aware. I'm
Go for it.
I didn't know. Um, you mentioned the note count, the overdue note count, and we had questions about that because we have associate licensed clinicians, so our notes are due after 48 hours, but then sometimes they're in the supervisor's mailbox. How do you have that issue, and how do you deal with that?
We do have that issue. That is actually why. So technically, our time frame that we would like to hit is the 48-hour time frame. What we have found though is that for our associate clinicians who are then pushing their notes into their supervisor's queue, there's like a bit of a delay. So they're pushing it to the queue, then the supervisor has to sign off. So what we've done is we indicate if notes are either both like if notes are not completed and if notes are unsigned. So I'll use the PracticeVital note report to look at both of those things. And that's one of the reasons why our time frame is the 24-hour time frame. Because what I'll do is I'll look and I'll say, okay, the notes are due in 24 hours. And I can see, okay, Sarah's note is not completed. It says like no note, it's not done, right? Versus if the note says unsigned, then I will take that report and I'll email it to both the supervisor and um, the associate clinician, and I'll say, okay, this note needs to be signed. So like who missed the signature
Oh,
here? Is this sitting in the supervisory queue or is this something, yeah, exactly, where it says unsigned, is this something that the clinician themselves started the note and didn't sign it? Like whose queue is it in?
oh, thank you. I never knew that was even there.
Yeah, that's been really helpful for us, really helpful. Other questions? I was just taking a look at the chat. Yeah, somebody has here. I'm just going to read this question. This is from Kathy. It's a great question. So, we're a small group practice. I'm the client care coordinator. I handle all the intakes and assign consultations and clients to the therapist. We found that maybe our therapists lack that sense of accountability because they just know if they lose a client, they'll eventually get new ones. We have Practice Vital, but haven't rolled it out to the team yet and want to avoid them feeling like it's a way to monitor them. What are your thoughts on this? Is there a way for us to start instilling more of a sense of accountability in our therapists before we roll out Practice Vital? This is such a great question, Kathy. I have a lot of thoughts on this. So one thing I think about is, yes, if they lose a client, they're going to gain a client. But from a clinician standpoint, one of the things I hear that contributes to anxiety or burnout from a clinical standpoint is I don't know what I don't know who my next client is going to be. What's the clinical that's coming in, right? What is the risk level that's coming in with this client? We're a DBT practice, so we do see clients who have a higher acuity. And one of the best ways that you can decrease that stress is to take the clients that you currently have and retain them. And so when you have a client and you've worked with a client for a period of time, that client is going to become more stable, they're going to learn more skills, and your burnout is going to go way down. So I look at it from the perspective of if I want you to feel successful in your position and I want you to feel good in your position, a huge part of that is going to be reducing your stress by helping you to keep the clients that you get. The other thing is for our practice, workload is a lot heavier at the start of a client coming into the practice. So when a client comes in, we're doing an intake. We might be doing safety plans. We're making sure we have all the needed consents. We're doing a treatment plan. We're doing a note. We don't have to do that every single time we see someone. We're doing those things at the start. So that's the other way that I'll frame it to our clinicians. Like you've put so much energy and investment into this start with your clients. So yeah, you could have another client come through the door, but what's the impact on you when you're just churning through clients? It probably doesn't feel good for you. It doesn't feel good for us to see that, right? We want to see you be able to make your connection and keep those clients. All of those things aside, it also can speak to trends of are you getting the right client for your skill set, right? So what is happening? If somebody's having a hard time building a caseload, say, and they're churning through intakes pretty quickly, well, what's going on there? Is it that there's a misalignment in that person's skill set or who they're getting assigned? So there's a lot of different ways that I might look at that and speak to. I always think about it, I'm a clinical person myself. I see clients, like I'm thinking about it, like what's in it for the clinician? Like how do I get their investment? And these are some of the ways I think it can help to build investment in, like, we can take these numbers and they can really help us to understand what's happening for you and to make sure you have more of the clients you want, more of the caseload you want, reduce that burnout that comes with churning through. If you're churning through clients, you're churning through paperwork. Um, and feeling like it's a way to monitor them. I mean, if it were me, I would just speak really openly to that. We're pretty transparent, and I would say, listen, like this could feel really uncomfortable, or like we're watching all your numbers, and that's really not the intention of it. And I think for me, like when I'm able to speak to all the other pieces of how it's going to be in the clinician's favor, it helps to get rid of that. But I would want to know, like, if somebody's like, I just feel like you're trying to watch my cancels and see when I'm in and when I'm not in. I don't know. Then I would just be like, okay, let's talk about that, and what feels scary or uncomfortable about it.
Yeah, and what I always say about that too is just what other field are you not having some kind of accountability or expectation from a boss? And there are timesheets, there's clocking in and clocking out at most jobs that kind of monitors the same thing.
Yep.
There's use of PTO, there's cancellations, like all of that is a part of every other industry. And I'm not sure where along the lines we kind of thought it was like we're in a hands-off industry, but our job is behind closed doors, and there's even more reason to make sure that what we're doing is effective. Um, I went to some training with Casey Compton a while ago, and she said something like, "Where else would you hand a employee $7,000 and say good luck and close the door?" Because that's basically what you're doing with a client. That's like the potential revenue, but also their care, more first and foremost. And then we're just saying, "Okay, go do it," and we're trusting that they're doing the best job, and hopefully they are. But there might be still areas that we can improve.
Yeah, I totally agree. I think no matter, like you're saying, no matter what you're doing, where you're working, there's always going to be some like level of accountability or metric or something that you're responsible for. I mean, we talk about that. It's great. We want everybody to have a good work-life balance, and we want to be a supportive work environment. And at the end of the day, like work is like taking something from you. That's the point of like you go to work, work, you earn money, you get a paycheck because you're giving something and you're getting something. And so of course there's going to be, standards and metrics that go along with that.
Interestingly enough, we also have solo providers who ask to sign up for Practice Vital. We don't have many who end up using it because I think it's just not cost effective, maybe in their minds, but people want to see for themselves, and they want an easier way to even see how many upcoming bookings do I have, what's happening with my clients, who's rebooked, just staying on top of some of that without having to resort to counting in the EHR or see their revenue data. So
Yeah,
uh,
I mean, I love it. I'm one of the clinicians, I'm a clinical director, but I see clients too, and I like going in and seeing my numbers. And I'm thinking, okay, I know I have a vacation coming up here, and I have a vacation coming up here. And so, how am I going to have to adjust my schedule to plan for that? And looking at my own revenue, I was one of the very first clinicians on the team. And so, when we first looked at, what is the average fee for session for clinicians, and I'm looking at clinicians who are like brand new to the field, and their fee is higher than my fee. I was like, wait a minute, what's happening here? I've really got to look at this. So that was really eye-opening. I mean, that was a while ago now, but it was helpful to see that information.
I think we have a couple hands up. Tia?
Right. I've been using Practice Vital somewhat for the last, I think, 2 years, but I'm not really very good at utilizing this great tool. One of the things that we were trying to navigate this year is, although we do similar to you, Lisa, where, they get 4 weeks of non-working time, so we subtract that from the annual number. I want to start tracking PTO in the system as a other activity category, for the reason being that, like, it's easier to see, if their numbers are low this month, it's a quick understanding versus trying to remember what was happening. And I'm curious if you or anyone has tried that and if there's been some cons to it. I do have my system set up to do it. We just haven't actually implemented it yet.
I mean, we don't formally track PTO because we are taking into account those 4 weeks that we're considering as a part of PTO time. I think for us, whether no matter what, like the yearly metric is the yearly metric. So even if somebody was using their PTO, we're not going to say like, oh, well, you used your PTO, so you didn't have to hit your yearly metric. So that's probably less applicable for us. Although I do think it shows trends in terms of when someone was like a little bit lower or their numbers. I can see what you're thinking there. Like it might help to tell the story. But we have also found, I don't know how you are, like how your business works, but for us, we find that clinicians' PTO for us is not always a good indicator of time in or time off because clinicians can also opt not to work and not necessarily use PTO. Or they could say, I'm going to see, 20 clients this week, but I still want to use 6 hours of PTO for this reason. So it's not necessary, it doesn't correspond directly for us.
That's a really good way to say it. And I haven't ever quite thought of it that way, but that's how I see it in my practice too. I really focus more on zooming out to the yearly goal, and I understand kind of the desire to check month by month, and but then that's why we also give you that average. And so you can see if somebody's falling below that average, they can also course correct along the way. And it's different than how you're probably tracking it before, where it felt important to each week send the metrics or to tell them where they were. But now that you have that average, it's almost you don't need the same it doesn't play the same role as it used to be able to know about the vacation in my mind. But I think every practice really does that differently, and some people even want to apply PTO to session counts, and I think you can do it. There's a lot of ways that make it really precise, but maybe more complicated, and so it's just kind of how you want to set it up and how you want to manage along the way.
Yeah, I think if my team just took their PTO the way like it's a week here, a week here, then it would probably tell a complete story. But I find, everybody uses their PTO and then some people take a lot more time off too because they might work partial weeks. And that's fine for them. And then they take, a long weekend where they've lost 2 days out of their week. So it's technically half a week, but they didn't use any time for that.
Mhm.
We did when we were doing our data manually. At that point in time, we had tried to track PTO, but I think in some ways it's simpler, just like looking at the overall picture, like you were saying, Tori. But I could see value in looking at trends and seeing what people do.
Mhm.
I don't know what other people do, but
Does anyone else want to speak to their way of doing it or any of that? We have one more question here with a hand raised. I don't know if you meant to keep your hand raised or not. Mindful Soul Admin. Were you finished with it? Okay, sorry about that. Yeah. Well, I want to take Lisa off the hot seat. This has been amazing, and just kind of also open it up to any other questions that people have, and maybe you'll still be the right person to field them if you're willing. But I also wanted to, I'm sure people will want to know how to get in touch with you. If you don't mind adding, if you're willing to share any contact info, in case people want to follow up about any of your coaching or leadership opportunities. If you want to put that
yeah,
in the chat, that's
absolutely.
great. And we can
That's
also
what I'll
share
do.
it. We can share it afterwards too.
Okay, yep, I'll just put it in the chat, my contact information. I'll put that in there now.
Yeah, I mean, it sounds like you have really amazing systems in place, and you've really worked data into an integral part of your practice, and it's really working for you. And that's why we wanted to really spotlight your experience.
Yeah,
Um,
thank you.
So thank you so much for sharing with us and helping us, everybody here, learn from you.
Yeah, thanks for having me. It's great.
Any other questions that people have kind of generally for each other, for the community? Again, we are here to help field, but this is really your opportunity to learn from each other too. So, a lot of times questions come up. People sometimes send us questions at support, and I say, that's a great question for the meetup because it's more of a community question. So feel free to ask those now. I'm looking at you, Wade, if you want to. You laughed.
I didn't want to put this one on Lisa just because but
Yeah.
the question I'm going to ask is,
Yes.
at our practice, we are contemplating adjusting retention from the default of 8 sessions to 12. Kind of with the mindset we're an in-network practice, and that as clinicians kind of decrease frequency with clients, that you start to lose a little bit of medical necessity. And so we wanted our metrics to align a little bit more with that model. I'm just curious if you've seen other practices do that, or if others on here have adjusted it. When I've started to float it, the initial impact is like, oh gosh, our numbers are going to tank. But also, like, I'd rather know that now than later. So that's kind of where I am with that question.
Yep. So wondering whether anyone's moved from 8 as kind of the minimum retention threshold to 12 or 10 and kind of what influenced that decision and how that's impacted you.
So our practice moved from 8 to 12, and it has taken time to start to see that retention build, but we're starting to see that we're actually providing more quality care by having those 12 session benchmark. When we did a lot of research into what does quality care look like for clients, we found that a lot of clients are actually getting that deeper work in when they hit that session 12 versus the surface level work. And there's less likelihood for a client to return to services if they do a minimum of 12 services. So our practice does benchmark 12.
Okay, cool. Thank you. So more successful discharges after 12 rather than having
Yep.
a lower number. Okay. Yeah.
That's really helpful.
Hmm.
And that is what some of that research shows that I had shared with you, Wade, too, is not just the client's successful, sometimes symptom reduction is what we see in those first 8 sessions. But in terms of lasting impact, avoiding returning in a few more months, it's really more 12 plus sessions. At the same time, I think it does scare people because they don't want to have a bunch of red on their dashboard and they don't want their therapists to feel discouraged.
Yeah.
So it's kind of, for one thing, you can always change the color coding to some extent if that's helpful, the metric thresholds. Um, but yeah, it can also be 8 is the baseline, and then we're really still shooting for 12. That can be the messaging around it.
Mhm.
It's really more about the messaging, I think, than the actual what you're looking at. Um,
I think our clinical directors are using the retention report and kind of adjusting, and like they will kind of walk through like, let's look what happens at 2 and 3, and so you'll see these drops. And so it's really helped us to have some important conversations of, folks will have a pattern of their people drop between session 4 and 5 or between session, 7 or 8, and it's like that's kind of been more helpful than the dashboard number, but just kind of trying to align the clinical conversation with the more like practice operational business side of it too. So yeah,
yes.
that's helpful.
Yeah, and I'm just showing this report in case you didn't know it's here under reports, retention report. It not only shows the average number of sessions per client with each therapist and then across the practice, but also you can go through and sort of see what happens at 3 sessions. Here we are at 93% for Tyler, and let's see what happens at 4 sessions. And, they're still at 93% for 4. So where do we have kind of our dropping off point? Is there a significant drop? Here he drops 6% between 5 sessions and 6 sessions. So is there a place where we can strategically intervene and help coach around that skill set? Maybe they're great at a first impression, which is more about churn, and they can keep those clients, they connect with them, and then the client comes back session 4, 5, 6 and is like, is this going anywhere? So, yeah, go through this report and see what kinds of insights you can come to, see if There are clinicians who are doing super long-term work. They might not always have the highest retention percentage, but they still might be, on average, when they keep a client, they keep them for 30 sessions. And so that tells you about the type of client or the type of work they're doing. Are they kind of polarizing as a clinician? Do they lose a lot of people? But then when it sticks, it really sticks.
Yeah. Cool. Thank you. That's helpful.
Awesome. Thanks, Wade. Other questions? We've got a few more minutes here.
One more question in the chat, Tori, from Colleen, asking what percent of utilization or clinician goal targets do people use as meeting the goal? Is it 85%, 90%? Obviously, you just spoke to that ability to adjust thresholds, but any further, insight would be great.
Yeah, I'll say first, I think 100% for utilization because we're saying this is the expectation. So if you set an expectation, then you say, but 90% is okay. I don't know why we wouldn't just set that as the expectation. I think it's a lot easier and cleaner to say, no, the expectation is 20 sessions a week, and that means 100% of that 20 sessions a week. That's how I feel about expectations. Because
Yeah,
where do we draw that line then? Yeah, go ahead, Lisa.
yeah, I was gonna say we probably do something similar. Like the expectation would be that somebody's gonna be at 100%. I think the thing that's maybe slightly different is the interventions that we put into place are different based on percentage of utilization. So somebody who's hovering like 95 to 100%, we're generally going to consider that that person is, relatively on track for their utilization. So this isn't somebody that we're going to implement, performance plans for or anything like that. And then when somebody starts to get into that 90 to 100%, we might be putting in a lot more interventions to try to coach that person up to get them to the 100% utilization. So I would say like the utilization, we still want to see someone at 100%, but how we use the varying metrics is to kind of think about what interventions do we put into place at each percentage to get somebody back on track.
That's awesome. Yeah, really helpful. And again, if you are thinking about it as somebody took time off and you're just looking at 1 month, maybe that's where you want to zoom out a bit and focus on the year to date or the last 12 months. You could do both. That's the nice thing about time frames is you can kind of see, is this just 87% from last month? And then, it was because they were on vacation or something. How are they doing this month? Are they back on track? And then, what about the last 12 months? How did Kevin look? Last question, anybody? Any others in the chat? Let's see.
It looks like Kathy was just asking for a bit more explanation or elaboration on the example you used, Tori, about a therapist doing a lot of long-term work, but their retention is still low. Because they seem to have a similar situation with one of their clinicians and don't quite understand why it's coming out that way in the numbers.
Yeah, and I think that's exactly what the retention report could show is, they're doing long-term work maybe with a handful of clients, but they're not getting most of the clients to the minimum amount in order to be successful. So if they do long-term work, but then still, 40% or 50 or 60% of their clients are dropping out before they've had that long-term work, then they're not really being effective. So it doesn't really matter what modality you're using. If you just say they do a lot of long-term work, are they being effective when they're doing the long-term work? And are they doing that long-term work with enough people? Does that make sense?
And I would like to add that when we see that, we go in and we dig in and look at all the churn and retention. We do this every Monday. If there's a churn or a retention, we go in and see what is the reason that they churned or what is the reason that they weren't retained. We put it on a spreadsheet under that clinician and put the reason by it. And we mark it green or red. Was it something that they were in control of, or was it something they weren't in control of? So for example, if the client was transition to Medicare and that clinician doesn't take Medicare and our practice doesn't take that, that's not the clinician's fault that there was an insurance change. Did the client move out of state? And so we go in and account for all of that. And then we do what's called an adjusted retention rate. And that's the data we present. And that's when we look at the trends. So if we have a clinician that has a lower retention rate, well, what's the difference between the long-term clients and the short-term clients? And then we present that to the clinician and problem solve. Is it a gap in skill set? We need to provide an additional training, or should we maybe not have them seeing those clients anymore and assign them the types of clients that they do well with? And so it really helps to go through client charts and dig through the data too.
Yeah, and you can go to this client's data sheet to look at a lot of that to decide, are they rebooked and, should we dig deeper? You can also look at client details, which can be helpful to see how often are they, just the patterns among the clients. But one thing I want to speak to about that is this idea of like, is it something they're in control of or is it not? I think there's a couple ways to look at that. One is we can think through every client and exclude them. And if you want to do that, we have the option of you can make a transfer out code or like a exclude from retention code, and we can exclude that client so that you don't have to do your own adjusted retention. But if you use that code, whatever code it is that you make up in your EHR that says transfer or, you know, not retained for a reason, we will exclude the client for you from the retention. That being said, the numbers, the percentages of 70% retained already accounts for there being clients that aren't in their control, right? I think, we can get super nitty-gritty about it, and say, this person went to a higher level of care. I don't want it to count against them. But I guess I don't always think of it as counting against them. It's just data. It's information one way or another. And so we don't really, I can see where clinicians might want each person to be exactly accounted for in your mind. But if you are clear to them that we know 100% are never going to be retained for that reason. And so the standards that are kind of in the tool are already representing that. So you could do it either way. You can do